Panelists and the faculty members. Madam, please. Since we are running a bit short of time, we have changed the talks a little bit. The first talk will be by Dr. Krishnan Sriram, who's virtually joining us from the United States of America. His talk was supposed to be the second one, but since it is too late for him, we would put his talk as the first one, and then followed by Dr. Apurba Bora, and then the list will continue as planned before. So Dr. Krishnan Sriram is an intensivist, telecritical care West, Veterans Affairs, Chicago, USA. He is a very well-known person in the field of critical care nutrition, and he will be giving a talk on the indications of parenteral nutrition. We welcome you, sir.
The topic of my presentation today is an overview of parenteral nutrition. During my long career, I've had the privilege and honor of working in Chennai, India, and in the 1990s, early part of 1990, I was one of the first to start parenteral nutrition in India, and compared to what we do today, that was primitive, both in terms of venous access as well as the products available. So what I'm about to tell you is actually based on years of experience, and I hope I can leave you with several messages. I would like to emphasize to you that very strict indications must be followed for the use of parenteral nutrition, which is one of the most abused pharmacologic maneuvers that are done, the pharmacologic interventions that are provided to patients many times for reasons that are really not well accepted. And we'll talk about different methods of venous access for parenteral nutrition, identify parenteral nutrition components, and how to avoid and manage complications. The decision when to use parenteral nutrition seems to be reasonably easy. However, it is not as simple as it seems. When you do not have any contraindications for enteral nutrition, you must use enteral feeding, either oral or enteral. It is only when the GI tract cannot be accessed or cannot be used should parenteral nutrition be used. Now, this may seem very easy, but let's go through this in a little bit more detail. Before we start on parenteral nutrition, what we need to ask ourselves is this: is parenteral nutrition really indicated? Has every effort been made to optimize enteral nutrition for at least 5 days? Have we tried the preemptive use of prokinetic agents such as metoclopramide? Have we stopped enteral feeding because the gastric residual volume was, let's say, 200 or 250? We know there's no reason to measure gastric residual volumes routinely. And just to start parenteral nutrition, because the GRB was high, is not really justified. Has every available option been explored to obtain enteral access? There is a jejunal feedings, for example, using a friendly radiologist or gastroenterologist. If we are not able to if you are not able to provide enteral feeding, has an opinion been obtained from a physician with more experience in this, either in person or via teleconsultation? And what is the source of payment for this product? In countries where the government pays for pharmacy products, including parenteral nutrition, it is overused because no one really worries about the cost involved, the cost benefit ratio. When the patient has to pay several thousand rupees for this, then we have to start questioning whether it is really needed. Insurance companies gladly pay for parenteral nutrition at several thousand rupees a day, mainly because the hospital administrators love the profit for the institution, but they would not pay a fraction of the cost for enteral feeding. Intrajejunal feeding should be explored in many patients where intragastric feeding is not possible. Small bore feeding tubes must be used with greater frequency, which can be positioned in the duodenum or jejunum easily, either through the nose or even through the transgastric route. During the COVID crisis, many patients were placed in the prone position. And this is, of course, as you know, for better ventilatory care. And the prone position was used by some physicians as a contraindication for enteral feeding. Nothing could be further than the truth. ECMO, or extracorporeal membrane oxygenation, is really not a contraindication for enteral feeding. There are, of course, certain rules that we have to follow if the patient is in shock, and the use of vasopressor agents, which we won't go into in right at the moment. But in general, ECMO is not a contraindication for enteral feeding. Prone positioning is not a contraindication, and neuromuscular blockade is not a contraindication. Now, there are, of course, certain conditions where immediate and parenteral feeding should be used when the GI tract is inaccessible or non-functional, complete bowel obstruction, short bowel syndrome, intestinal failure, or a high output enterocutaneous fistula, more than, let's say, 500 cc's of drainage per day. But in other conditions where some amount of enteral feeding could be used, we use supplemental parenteral nutrition. There are conflicting opinions in different society guidelines. The Europeans say you have to make up calorie and protein deficit within 2 to 3 days. The US guidelines say do not use parenteral nutrition at least for 7 to 10 days. The truth may be somewhere in between 5 days, 7 days perhaps. And during this time, every attempt must be used to obtain enteral nutrition access. You feed the patient, even trophic feedings, hypocaloric feeding. Only then you resort to supplemental or total parenteral nutrition. Giving the patient parenteral nutrition too early is actually dangerous. COVID is one exception where enteral feeding cannot be achieved easily for various reasons. And in these instances, aggressively pursuing early post-pyloric feeding, continuous volume-based infusion is justified. And we liberalize the use of supplemental parenteral nutrition under these circumstances. Parenteral nutrition is given to the patient through unnatural access routes, not through the umbilical cord as we were warned, but through central veins or peripheral veins. It contains components that are artificial. Fiber, of course, cannot be given intravenously. Glutamine only on a limited basis. L-carnitine is never available to be added to parenteral nutrition. There is no first pass effect to the liver, high incidence of dysglycemia, and there's a higher mortality shown in this slide, which of course compares parenteral nutrition with no nutrition at all. You'll find that parenteral nutrition doubles the risk of dying. The protein catabolism, autocannibalism that occurs in systemic inflammatory response syndrome is thwarted or attenuated only by enteral feeding, not by parenteral nutrition. This editorial that I had written some years ago shows that parenteral nutrition increases the fat content of muscle mass and not the actual muscle itself. And therefore, parenteral nutrition does not help us in terms of cutting down the stress response. Parenteral nutrition is given either peripherally or centrally, peripheral vein or central vein, and it is called either supplemental nutrition, where you supplement enteral feeding, or total parenteral nutrition. Central vein parenteral nutrition can be given for several days, some cases several months too. The osmolality of the solution is over 1000 milliosmoles per liter, and the high flow vein, such as the subclavian and the jugular vein, is tolerant. The peripherally inserted central catheters, or the PICC lines, are actually becoming more and more popular for the administration of central vein parenteral nutrition. Peripheral parenteral nutrition is usually used for less than 15 days, mainly because there's a higher incidence of thrombophlebitis. To keep the osmolality low, there's a higher lipid content in peripheral formulas. Higher volumes are actually needed. And it is because of thrombophlebitis that whenever a patient needs parenteral nutrition for a longer period of time, a central vein is always desired. Parenteral nutrition is made up of several components: dextrose, lipids, amino acids, electrolytes, vitamins, and minerals. Now, there is no such terminology as partial parenteral nutrition. Partial parenteral nutrition is a term that's used in many Asian countries where only one component, such as amino acids or fat emulsion alone, are given. There is no such terminology. There is no indication to use intravenous proteins alone, intravenous amino acids alone. The glucose content of parenteral nutrition is calculated as 3.4 kilocalories per gram because it is a hydrated form of glucose, and it is in a 50 to 70% concentration. The protein is 4 kilocalories per gram, varies from 3.5 to 15% concentrations, and lipid emulsions are traditionally soybean or safflower oil, or a mixture of the two. Now it is both 10% and 20% are available. The recommended maximum dose is 1.5 grams of fat per kilogram per day. The osmolality is because of sorbitol. That is why, whether it is because of 10% or 20% fat emulsion, osmolality is almost similar to around 300 or so. If you give plain fat emulsion without the addition of sorbitol, then the blood will actually hemolyze in proximity to the infusion site because it is there is no osmolality in fat emulsion. The newer lipid emulsions contain medium chain triglyceride and long chain triglyceride, the so-called MOSF triglycerides, olive oil based, omega-3 fish oil, and we will not go into the details of the newer kinds of lipid emulsions. Use whatever is available in your hospital. Now, lipids are an integral part of parenteral nutrition, and they form the essential component of daily non-protein calories. 2 to 3 infusions a week were used earlier to prevent essential fatty acid deficiency. Glucose levels fluctuate rapidly if lipids are given one day and not given the other day. And there is generally no contraindication for giving lipids even in liver enzyme elevation because the lipoprotein lipase needed to metabolize fat emulsions are present only in the capillary endothelium in humans and not in hepatocytes. We should consider the electrolytes that are lost through wound, the GI suction, ostomy, emesis, and diarrhea, and additional electrolytes may have to be added into the parenteral nutrition in addition to whatever is innately present in the formula. The best way to provide parenteral nutrition is a 3-in-1 delivery system where you have the lipids, the amino acids, and the dextrose all in separate compartments, and the breakable partition is broken by putting pressure on the two. Lipids are mixed at the end, and there is a side port for adding electrolytes. For example, if you want to correct acid-base balance, if the patient has metabolic acidosis, especially hyperchloremic metabolic acidosis, then you can convert some of the sodium chloride to sodium acetate. And some medications can be added. We prefer not to add insulin to the parenteral nutrition in the critically ill patients. We must always keep a good stock of both vitamins and multiple trace elements, zinc, selenium, copper, chromium, and manganese. In kidney failure, we may have to restrict some of the vitamins A and D. Now, this is a paper in which I was proud to be an author, which was published by an international consensus society, mainly to sensitize physicians that micronutrients should be added to all parenteral nutrition formulas. Now, although this is recommended, it is not always followed because of delays in initiating and because the optimal formula may not be available. In certain situations, you may have to add extra vitamins or trace elements, but in general, at least the daily requirements must be used. And this publication was actually an effort to sensitize clinicians to the role of micronutrients as an integral component of nutrition therapy. The European Society has recently said that thiamine should be given to all critically ill patients while enteral feeding is being progressed for the first 3 days, 100 to 200 milligrams. And because patients may not get adequate amount of enteral feeding during the first few days, even if you do not use supplemental nutrition, at least the multiple micronutrients must be given intravenously or, if possible, enterally or orally. Now, for TPN to be successful, you need a central line, and you're all quite familiar with all the complications, the mechanical complications that can occur with insertion of central lines, and with use of ultrasound, certainly these complications have become less and less. But after the catheter is put in, you may have a lot of infectious complications or mechanical complications such as catheter occlusion, catheter malposition, and phlebitis. Catheters can break and can also embolize. And those of us in critical care familiar with central lines are also able to manage this quite well. But the metabolic complications are more serious. Hyper and hypoglycemia, electrolyte imbalance. You must make sure the non-protein calorie nitrogen ratio is okay. Disturbances in acid-base balance can occur. And refeeding syndrome is more common with parenteral nutrition because some of the complications of enteral nutrition are not present here. Low potassium, magnesium, and phosphate, and recently thiamine deficiency has been included as a component of refeeding syndrome. We have to monitor the glucose, fluids, electrolytes, triglycerides. Up to 450 is acceptable. And when the triglycerides are higher, there's a limited role of heparin to stimulate lipoprotein lipase to bring down the triglyceride levels. But catheter infections are very common, and hand hygiene and using antiseptics and preferring to use single lumen catheters or multiple lumens are used, use one dedicated only to parenteral nutrition. The disinfectant strategies you are all very familiar with. It is not the parenteral nutrition itself that increases infectious complications. It is actually the management of the catheter site. When multiple lumens are used, make sure that saline is used in the lumens to lock it. But there is no real evidence to show that inline filters or routine replacement of central lines or antibiotic prophylaxis are useful. So the key points in the talk are parenteral nutrition should be given only when indicated, delivered through central or peripheral veins. Complications do occur but can be minimized by preventive measures and by following strict protocols and training. Thank you very much.
Thank you, sir. Thank you very much. We'll take the questions in the end if it's okay for you, sir.